Yeah, good morning. My name is Kenneth Moise. I'm a professor of women's health at Dell Medical School at the University of Texas at Austin. And my interest throughout my career has been to deal with hemolytic disease of the fetus and newborn, and I'm happy to be here today. Yeah, great question. So we know the FcRn, or what's called the neonatal Fc receptor, is the primary receptor to transfer antibody from the mother to the fetus. It's on the placenta, there's lots of it. And it's very useful because babies get their immunity from their mother, at least in the early days of life. They get, if you would, inherit their immunity from their mother. So, for the most part, good antibody crosses the placenta, but in cases like red cell immunization, bad antibodies can cross also. So by targeting FcRn, you in essence block the placenta and don't allow the passage of antibody. Now, unfortunately, you take the good with the bad. So you block all antibody. It's not selective. So you're taking the good antibody from crossing and you're also keeping the bad antibody from crossing. The other part about FcRn receptor blockade that most people don't remember from immunology is that it lines the blood vessels of any patient. And it sort of accounts for how much IgG is circulating in your bloodstream. So why is that a good thing for us to target that receptor? Well, when the receptor works, it sort of salvages or protects your IgG levels by keeping them from being degraded. So you have a maintained level of circulating IgG. But when you block FcRn, the antibody gets into the endothelial cell and then it's degraded. So what does that mean? Now your circulating level of IgG drops. And again, unfortunately, it's all IgG, which we can talk about in a minute. But the bad IgG, say anti-D or anti-Kel, also the titer drops. So when you target FcRn in alloimmunization, you actually target two different approaches. First, placental passage, which is blocking that, and you also drop the maternal titer. So it's a dual approach. Yeah, so we really spent a lot of time early along making sure that this antibody didn't cross. So there were a lot of preclinical studies done in monkeys, and then there was actually some studies done in a what's called in vitro placental model to show that very little NIPO crosses into the fetal circulation. Nipocalimide is tightly bound to the Fc receptor. It doesn't come off. And so basically, once it binds, it's very difficult for it to cross into the fetal circulation because the Fc receptor doesn't cross into the fetal circulation. So what the study showed, small number of patients, was that when you look at blood levels in the baby, either at the time of cortocentesis during the pregnancy, where we take a sample from the umbilical cord while the baby's still in utero, or cord blood at delivery, there were almost undetectable levels of NIPO present, indicating, as we suspected from the early studies in monkeys and in vitro, that it would not cross. It's not true for all the FcRn receptor blockers that are on the market. So there are several others out there being used for myasthenia gravis and other diseases. This one is so tightly bound that it stays on the maternal side and doesn't cross to the baby. And so we didn't see any really significant blood levels in cord blood in utero or at birth, which was very good finding. So one of the big concerns we had as we began this study was we knew that the FcRn blockade would block all the antibodies, as I mentioned earlier, even the good antibodies, which meant babies would come out with less immunity that they normally inherit from their mother. So we were concerned about that. In the study, a large percentage of the babies got IVIG, intravenous immune globulin, to sort of support them, if you would, in early life. Some didn't. But whether they got it or not, their antibody levels did drop a bit, as you would expect them to do. So normally when you get your antibodies from your mother at birth, you have a sort of significant amount of antibody in your bloodstream, but it drops on out and the baby has to start making its own antibody. And so, in fact, that's what happened in the study. So they natered, the levels in the babies natered at about 4 to 24 weeks, and then they started heading up into the normal range. What's most important is despite that, and we know this happens, Nipple doesn't affect all your other immunity, your T cells, your IgM, your IgA. None of those antibodies or T cells are affected by Nippo. And so the proof in the pudding was how did these kids do for infection? Did they get weird infections or serious infections? And the answer is they didn't. They had the usual runny noses, conjunctivitis, otitis media. One child did get RSV sometime out, was in the hospital for 5 days, but ultimately did okay. One child got COVID way out, but did okay. So we didn't see, it's a small number of patients, only 12, but at least right now, with the data we have, we didn't see any overt infections in these children, even though some of them had low IgG levels initially. So they seem to be able to respond to infection, and they seem to be able to handle their typical pediatric infections. So I don't think all the data is in yet. In the monkey studies, we studied vaccination in the monkeys, and in fact, the newborns and the neonates responded to vaccines. In this study, the great majority of the children who got vaccines responded to those and had good blood levels in their but it was only one vaccine that we studied, and it was, again, a small group of children. So at this point, again, we're reassured that they will get a response to their vaccinations. The phase 3 trial that's ongoing, called the Azalea trial, is going to have a much larger number of patients than the 12 that were born. And the answers really won't be in until we get those babies back. So once we can watch the immunity in those children and see how they respond to vaccines, we won't have all the answers. I can tell you that the oldest phase 2 baby born is probably 6 years old now and doing just great. So we haven't seen anything really bad happen with these children, but we need more data before we can say, hey, it's totally safe and the babies are going to be fine. So more to follow. Yeah, this is really the moonshot. I mean, basically, if you could treat this disease medically right now, the standard treatment would be to use serial ultrasounds to detect when the baby's anemic. And then when that happens, you have to take the patient to the operating room and put a needle in the umbilical cord and give blood cells, compatible blood to the baby. And you don't do it once, you do it 4 to 6 times during the pregnancy. And each time you do it, there's a risk to the baby being born prematurely or even losing the baby. So if we could move from a surgical treatment, which has been around for many years and has a pretty good success rate, to a medical treatment, well, that does two things. First of all, anybody could be treated in a community hospital. You wouldn't have to come to a specialized center. And secondly, the risk of having an invasive procedure where we're trying to hit the umbilical cord to give blood to the baby, that goes away. So I think this is a real game changer when it comes to treating this disease. And what I love about this is there's 3 or 4 other diseases in pregnancy, for instance, congenital heart block, or another disease called FNAIT, which is almost equivalent to RH but involves babies' platelet counts. Those could be easily treated with the same approach. So once we show this is effective with HDFN and we show the safety of it, I think you'll see this being used in other situations in the future. There are ongoing studies right now being done in FNAIT already with this particular drug, and understand a different drug is being used in a trial for congenital heart block, again, caused by antibodies moving from the mother into the baby and causing damage to the heart. So this approach could eventually be used in other diseases where we see fetal problems coming out of the maternal antibody.